Hi, good morning, good afternoon, and good evening, everyone. I am Mehnaz Khairandish, Regional Advisor for Evidence and Data to Policy in the Eastern Mediterranean Regional Office for WHO. Welcome to our second workshop of our virtual workshop series on grade methodology. And I can see many key and well-known experts with us today. We have Dr. Lubna Ansari and other colleagues. Thank you so much for joining. If you have attended the first workshop on 30th of October or have seen our poster, you know that in the first workshop, we explained the grade methodology and its approach for appraising and using evidence for policymaking. And we described some of the common tools such as evidence to decision framework in that session. In this workshop, in our today workshop, our focus is on the guideline adaptation process and the methodologies to be applied for adapting the recommendations from one setting to another setting, considering local context and capacity. We will also explain how evidence to decision framework can help this process, while we will present some of its challenges. We will also describe what do we mean by national program for guideline adaptation at the country level. And at the end, we will introduce the Eastern Mediterranean Regional Roadmap for establishment of the national program for guideline adaptation in the region. I would like to also say that this workshop series will be followed by more events on evidence-informed policy making and available tools and approaches to enhance this capacity in the country next year. And also, please note that our third workshop will be held on 11th December, that is on grade circle approach. And as we also said in the last workshop, in the previous one, the aim of this workshop series is to enhance our capacity for generation of evidence and using the best available evidence to inform policymaking for health and to institutionalize this capacity within the health system in the countries. So today we will have 3 technical sessions that will be delivered by my esteemed colleagues, Dr. Eli Ag, who is the Professor of Medicine and Director of AUB Grade Center, and Dr. Arash Rashidian, who is the Director of Science, Information and Dissemination in the WHO Regional Office for Eastern Mediterranean. We will have a very short break, about 5 minutes, and also a session to hear from you about your experiences and to share your opinions and feedback with us. Please use chat box for asking your questions and for sharing your comments with us. And also during the session, my colleague Malika, she will share some of our sources related to evidence-informed policy making. That would be great if you once in a while just check the chat box to copy the links or download the files for your future reference and use. I wish you will find this workshop helpful and relevant to your needs. And so by this, I would like to invite our first speaker, Dr. Eli Ag, for his kind presentation. Thank you, Dr. Eli, over to you.
Thank you, Dr. Mehnaz. Thank you for the invitation. Thank you for the opportunity to present. Thank you for WHO EMRO and Dr. Rashidian for all these efforts that are important for the region. I would also like to thank all the participants for joining us today. And also thanks to Dr. Lubna. It's an honor to have you with us. Great seeing you. I'll go ahead and share my slides. If someone could please let me know whether you could see them.
Yes, we can. Go ahead, please.
Okay. 1 second. Okay. So as Dr. Mehnaz mentioned, this will be workshop number 2, and the next workshop should be exciting, tackling a very interesting issue around qualitative research and assessing the certainty in qualitative research. So these are my disclosures. And I would like to thank Ms. Joanne Khabsa for helping with the presentation and for helping today, similarly to last time, in managing the questions in the chat box. A quick reminder about what we covered in the first workshop, which was an overview of the grade methodology. We discussed key principles and concepts, discussed the grade evidence to decision framework. We will come back to this framework today. Key considerations in developing those tables, and we went over some case studies. And I'll give you a very brief reminder of some of the things we covered. And by the way, just to say that we will be sharing the slides with you. So we covered first the concept that there are three approaches to guideline development: the standard development of your own guideline versus adopting the source guideline from another organization, or the adaptation of the source guidelines, which is going to be the focus of today. We also discussed in that first workshop the decision-making process. In other words, how developing recommendations is a decision-making process. We covered who is making the decision, who are the different stakeholders, what are the options being considered, the factors based on which the decision is made, and how to judge those factors based on what decision. So those factors were probably the most important part of that presentation. And if you remember, the way we conceive those factors that affect the recommendation are in two groups. The first set of factors, we think of them as evidence on the health effects. What is the effect on reduction in mortality? What is the effect on increase in any side effects of an intervention? And the second set, as important as the first set, is the evidence on contextual factors. Talk about resources, equity, acceptability, feasibility. And we call them contextual factors because they vary by context and because they are very important when we adapt the recommendation. And we went over an example of using one of the software, Grade Pro. You could have data describing acceptability. You would have a judgment from the panel on the left-hand side. And this snapshot summarizes the judgments for the different factors. In this case, the panel decided or judged the desirable effects to be small, the undesirable effects to be moderate, based on very low certainty evidence. And you could see the different judgments, for example, acceptability, yes, acceptable, feasibility, probably acceptable. And the panel would, based on these judgments, come up with an overall assessment of what the recommendation would look like. In this case, they decided to go for a condition recommendation in favor of the intervention. And then comes the more detailed text, which is the recommendation and the remarks that go underneath the recommendation. So that was a quick summary of workshop one. Again, guideline development using the evidence to the decision framework. In this workshop, we're going to switch gears, discuss guideline adaptation, and then talk specifically about one of the approaches to guideline adaptation, which is grade adulthood. Okay, so let's go. So these are the different steps. So what I will do, I will share with you this tale of two guidelines, just to give you an idea. So a source guideline and an adapted guidelines. And we go through the process of what happened. And this will help us reflect a little bit about, the difference between the two processes, developing your own guideline versus adapting, the pros and cons. So these are the two guidelines. On the left is the source guideline, which is the guideline on the treatment of rheumatoid arthritis, developed by the American College of Rheumatology in 2021. On the left is the adapted guideline, which was adapted by the Saudi Society for Rheumatology. and produce this document. And this is what I'm going to tackle. How do the guidelines compare? The timeline, the number of recommendations, data gathering, logistics, cost, and modifications. And I invite you, if you are developing your own or adapting your own guidelines or planning to adapt your own guideline, to think about how the information I'm sharing relates to your own experience. And it would be great if when we have the Q&A session, you could share your own experience. So let's start with the timeline. The ACR, American College of Rheumatology source guideline, started in August 2018. From start to drafting the recommendation, it took them 17 months, so about 1.5 years. And I would say that's probably typical of a guideline project. From start to submission, it was 31 months. So you see there's a bit of 14 months between drafting the guideline and the submission. And the reason for this is because major organizations have lots of levels of approval within their different committees, etc. Start to publication, 35 months. So 4 months from submission to the journal to publication, which is not bad. Now, how does the the Saudi Society for Rheumatology project compare? So the project started in October 2021. So this is just a few months after the publication of the ACR guidelines, which is good. Start to drafting the recommendation, 3 months. So it was a very efficient process, although, as you will see, it was a rigorous process when we talk about adaptation. So, much shorter timeline. From start to submission for publication, it was relatively short, 6 months. So the panel itself was done with the whole work, including drafting the paper and submitting for publication in 6 months. Compare this to 31 months. Start to publication, 14 months. You see, this is a problem here that we encountered with publication, which is about 8 months. But probably that's a different issue. I think the key point here is that the efficiency of the process going from 31 months to 6 months. So that's the timeline. Okay, now let's go to the number of recommendations. So the source guideline had developed 81 recommendations. That's a huge number of recommendations, which is important because the audience of the target users of the guideline had lots of questions about management of rheumatoid arthritis, and ACR had to address those. So they had a large number of recommendations. Now, the adaptation process just tackled 5 recommendations. Why 5 recommendations? One, because there were some more limited resources, and we'll talk a bit later about resources. But the other reason is they needed to tackle those recommendations that are context sensitive, meaning that some recommendations, if you take them from another guideline, you could just apply them as is. We think back about the COVID-19 pandemic. WHO had a recommendation on using steroids for the treatment of critically ill patients. And you could imagine that this recommendation could be adopted without much effort. It was a strong recommendation based on high certainty evidence for a medication that is really cheap. So there's no much need for contextualization. So these ones do not need to be adapted versus other recommendations where you have very expensive drug, for example. So anyway, we ended up with working on 5 recommendations for adaptation. And the question comes up, what happens to the other 76 recommendations? So the 76 recommendations, there was a decision to adopt as is. So you see, this is an important point. So this document comes out and say, there's 76 recommendations where we felt there's no need for much effort, adaptation, contextualization. There were 5 recommendations we felt that might change when we adapt them to the Saudi setting, and this is what the document focused on. So in terms of data gathering, and as we know, data gathering is a major undertaking in a guideline effort. So when we talked about ACR spending 1.5 years working on their guidelines until the draft of the recommendation, most of this time was spent on data gathering, including what? So one, systematic reviews on the health effects of all the interventions tackled in the 81 question. Just imagine the amount of data. There was a systematic review also on harms, another systematic review on minimally important difference, a concept that is important when trying to interpret continuous data. There was a systematic review on values and preferences. For those of you who attended the first workshop, you might remember that values and preferences are key to interpreting the size of the effects of an intervention. ACR also collected data on the cost of the intervention and on cost effectiveness. So this is what most of the time was spent on. So now the question becomes, and this is a question to you, when the Saudi panel looked at those, which ones did they decided to reuse, meaning not to recollect the information? If you could share or if anyone would like to speak, please feel welcome just to use your microphone. Or in the chat, just share with us what you think that could be reused, meaning that was done for the ACR and could be reused for our setting. So the background for this question is that adaptation is done to save resources, so time and resources, not to redo some of the work. Another way to think about it, which one, so let's ask that question, which one you would not use when adapting to the local context? Which data used by ACR for their own US-centric guidelines you would not use when developing your local guidelines? Which one of those? If you want to just nominate one of them.
Hi, this is Dr. Nathan from Department of Planning of Kuwait. The one that would make initial response that data on cost and cost effectiveness might not be adopted as it is, because cost and cost effectiveness might depend on many factors that are beyond just the immediate cost of the intervention. So I would say that this would be my initial reaction.
Perfect, thank you. And actually, you will see on the next slide that these are the two aspects that were not used by the Saudi panel. And there's a comment from Dr. Vahid that it's cost effectiveness and values and preferences. And I think this is an important point. Actually, the Saudi panel looked at the findings of the systematic review on values and preferences, and we asked them to judge whether these values and preferences identified in the literature would be consistent in the local values. And the judgment was that yes, and we went with those. So that's definitely an issue to keep in mind, to validate whether those are relevant. And this is important because the first 4 checkboxes we're talking about a huge amount of time that you could save, and we're talking about a huge amount of money. These systematic reviews were commissioned, and they cost money, they cost time. So what the Saudi panel did, as part of the adaptation process, use or take advantage of what has been done and not replicate the work, but then do its own data collection on cost and cost effectiveness in the Saudi setting. Another important issue that the Saudi panel did is that they updated the search for new studies published since ACR was published. So remember, it was about 4 to 5 months between the publication of the ACR recommendations and the Saudi effort. However, the date of search for the ACR guideline was a bit like at least 1 year old. So we updated the search, and interestingly, we did find one additional study that was published after the search done by ACR. And we'll get back to this when we talk more about the details of adaptation. So Now moving to the cost, we talked about saving on resources, avoiding duplication of work. What do you think about the cost? Any comment about, and it's hard to say how much each of those cost. And personally, I don't have the information, but I'm just interested in your guess about how do the costs compare. If you could throw any guess, we'll guess together. So there's no right answer because I don't know the answer. I just have a guess. So any guess from your side? Yeah, I think people are just looking at the chat. Okay, it might be a tough guess. So I'll tell you. So typically the cost of a guideline, develop a new guideline, is in the order of the hundreds of thousands. So we're talking about, 200, 300, in some cases for some of the nice guidelines, so nice in the UK and signed in Scotland. They talk about, million or £2 million to develop a source guideline. I have no idea what ACR had to pay for this, but in the adaptation processes we've been involved in, the range or the magnitude of costs is around, let's say, 10 to 20K, 30K, 30,000. So divided by almost 10. So there's a divider of 10 between the cost of the source guideline and adaptation. So that's a bit of saving. Logistics, just to give you an idea, this is on the left is the ACR guideline. It was an in-person meeting in Atlanta. So imagine flying people for the States, experts, people from the States, us, the systematic review team and the methods team that had to fly us from Lebanon, and then the venue, etc. So this by itself is a lot of cost. For the adaptation in the context of the Saudi Society of Rheumatology, it was all online. It was convenient. People had used to Zoom since the times of the pandemic. We did it kind of in the midst of the pandemic. So just compare or imagine the difference in cost and logistics and the convenience. Because one of the advantages of Zoom is that it's not really hard to schedule. If you want to bring 30 experts around the table, you have to start scheduling probably 6 months ahead. And there's a chance that some people might not make it, either because of schedule or sometimes logistics, last minute logistics. Versus Zoom was very convenient. And even major organizations now are starting to use Zoom, at least for part of their efforts. Now, this is the part where we talk about some of the modifications. How did the recommendations change? So, excuse me, let me walk you through this slide. On the left in blue are the original ACR recommendations. On the right-hand side, are the adult recommendations. So the first you see in the middle, these are the number of the recommendations that have been adapted. You will see that the first one, and you don't need to worry about the exact, what are the interventions being compared, just to illustrate. The panel decided to not modify the recommendation. It was the same. For the second recommendation, they went from sulfasalazine over methotrexate to the opposite. So they went from recommending A over B to recommending B over A. And I'll show you very shortly why. Another set of recommendations also here, 1 out of 2 was changed. Again, the ACR had recommended against, recommended in favor, and then the 5th recommendation was not modified. So the point I'm trying to make out of this slide is that when you adapt a recommendation, it doesn't mean you have to change the recommendation. The adaptation means that you went through the process of considering the contextual factors. In some cases, the contextual factors led you to change the recommendation or to modify it. In some cases, the contextual factors are either similar or different, but not really different enough, or different or led to the change of the recommendation. So that's the point out of this slide. So this is the one example I wanted to share with you, just to give you an idea of what the panel discussed. So this is a recommendation about sulfasalazine, that's ACR, the Americans recommending sulfasalazine, condition recommending it over methotrexate. The Saudi panel went the opposite way, where they recommended methotrexate over sulfasalazine. So this is the justification on the left by ACR, saying that sulfasalazine is recommended over methotrexate because it's less immunosuppressive, and the patient panel felt that many patients with low disease activity would prefer to avoid the side effects. So you see the main driver in that recommendation were side effects. On the right-hand side, so first let me tell you that you could see that the remarks are better organized and more detailed. So the first one clarifies that this recommendation was modified and in what direction. So this is important when you present an adapted recommendation to state whether it was modified or unmodified. Second, this recommendation applies to patients with low disease activity. So this was felt by the Saudi panel to be important to highlight. The choice should account for the patient's views on the expected benefits and harms. And this is really important. So emphasizing individualized decision-making, because you will see that the shift was a bit based on how much weight we give to the side effect. So in spite of the modification, the panel wanted to clarify that it is up to the patient to make the final decision about the importance of the harms and how to deal with them. The choice should consider the availability of the medication. And this was an important issue. When the panel discussed this recommendation, an issue came up about the availability of some of those medications in different healthcare systems in the Kingdom of Saudi Arabia. Because as in many countries, you have different healthcare systems, public, with the government and some other parallel health systems, and apparently there were different availabilities. So that would have to be reflected, that in your context, you have to think and consider what is available, what is not. And it is important to monitor adverse events and adjust medications. And then the rationale for the modification is that the panel favored methotrexate because of the dosing convenience, which is once weekly, and its low cost compared to sulfasalazine. So in essence, we're saying that in our context, people would value more the convenience just to get it once weekly. There's an issue of cost. Methotrexate is much cheaper. However, we still say we should involve the patient in that final decision. And this is kind of summarizing the point I just made, plus saying that the Saudi panel was less concerned than ACR panel about the hepatotoxic side effects of methotrexate in relation to alcohol, given this is not a concern in the Saudi setting. So the Americans were very concerned about that side effect. And the Saudi panel was more attentive than the ACR panel to the potential side effects of hydroxychloroquine, which is another sub-recommendation, given the high prevalence of G6PD deficiency in KSA. So see here, it's really interesting how the contextual factor is really important in terms of the culture and how the culture can affect the recommendation, but also the epidemiology of diseases like G6PD deficiency and its relationship to some of the side effects. So to close this part of the presentation about the tale of those two guidelines, I wanted to reflect with you on two comparisons. So comparing one, the development of your own guideline versus adaptation, and the adaptation versus the adoption. So let's start with comparing own guideline to adaptation. So if you develop your own guideline, or if you do actually the adaptation, you need less time. We've seen the example. You need less financial and non-financial resources, which is important. However, two disadvantages: you have less control over the questions addressed. So are kind of limited by whatever the source guidelines addressed in their recommendation, meaning that if there's a question that is locally relevant that was never addressed by any of the published guidelines, you are kind of limited when you are adapting. And then you have less control over the methodology use. We talk a little bit about methodologies, and you might prefer a certain methodology, but then you end up having to deal with a guideline that uses potentially a different methodology. So these are the limitations. When you compare adaptation to adoption, adaptation leads to more contextualized recommendation, meaning that adoption, you just copy paste. So think about adoption as copy paste. Adaptation, you take the context into account. We gave the example of the hepatotoxicity, the example of G6PD deficiency in terms of epidemiology. We gave the example of the prices, preferences for convenience, availability of the medications in the healthcare system. Still, adaptation requires more time and resources. We've seen that with the example we gave you, it took 6 months to do the work. Adoption is technically copy-paste, could be done very quickly. So here I would like to, stop for a minute and then just get your point of view on this. And based on your own experience and based on this comparison of, the two guidelines, what do you think are the main advantages of adaptation? So again, please feel free to either type in the chat box or just use the microphone. No need to raise hands. Okay, so we have local applicability, yes. Sorry, I missed that. Let's see, cost and savings, definitely. So this is one of the major advantages. Saving time and effort by using the published evidence tables and or recommendations, yes. Local applicability, yes. And I think that, thanks everyone. I think that captures the main ideas. And, we like to think about them in two buckets. One is efficiency and two is contextualization. Efficiency, because as you've mentioned in the chat box, you are saving on time, resources, expertise. Some of these guidelines, they bring world experts in a certain field and, they get the expertise into this. And this is already done for you. So you could use that. So that's efficiency. But contextualization is also important. It allows you to take that data, take those systematic reviews and the findings and contextualize to your own context. And if you remember, we discussed last time and we did a couple of exercises on the importance of the baseline risk of disease, the importance of the values and how we think about values, etc. So keep those two in mind. And as we go through this presentation today and through this discussion, the aim is to think about how to be efficient and how to maximize the contextualization. So talking about optimizing guideline adaptation and efficiency, we need to efficiently use existing guidelines and systematic reviews. We say guidelines and systematic reviews is because sometimes you don't identify a guideline answering your question. As we said, you might have a question that has not been addressed by any guideline. So instead of giving up and saying, we're not going to have an answer, you could keep that question and go and identify published systematic reviews on that same question. And it's really important to have a process to identify guidelines and systematic reviews and to assess them. The other part is contextualization and grade development, something we'll cover in the second part of this presentation, was designed to achieve these two goals. So by design, when it was designed, it had those two in mind. We published this review of the frameworks for adapting guidelines a few years ago, 2017, and we identified at the time 8 proposed frameworks. There are more now. The one that was mostly used, and you might be familiar with this, is Adapti. So Adapti takes the credit for being one of the earlier well-designed frameworks. It's been used for a while, still being used actually by many groups. The challenge currently with Adapti is that it predates major advancement in guideline methodology, particularly in relation to the certainty of evidence assessment and contextualization. So that's why we've seen, since Adapti was published, since these advancements, we've seen a few methodologies published in this area. So the methodology that our group has developed, I'm talking about the grade working group, is called the grade development. It was actually developed in the context of a project with the Saudi Ministry of Health to adapt a number of guidelines, again, a few years ago. So what grade development does is that it integrates adoption, adaptation, and de novo development. Adoption means, as in the example I gave you, you look at the list of 81 recommendations. For some of those, and this would be based on the panel judgment, it's too obvious that they wouldn't change, they wouldn't be modified, and they are adopted as is, the copy-paste approach. Some of these would be judged that they might be context sensitive, so you would take them through the process of adaptation. This is the example of the 5. And de novo, this is when, okay, we've had the 81 recommendations, we've either adopted or adapted, but then you say, I have this extra question that is relevant to my audience locally, but has not been addressed by others. And this is where you do your de novo development of a recommendation, just 1 or 2 recommendations. The other aspect is that it uses the ETD, or the evidence to decision tables, to contextualize. And what do we contextualize? Local epidemiology. We gave the example of G6PD, but there are many other examples, like the incidence of breast cancer, or we face this frequently in the region when we adapt guidelines for breast cancer screening. The local expert will say we have a much higher incidence of advanced breast cancer at diagnosis compared with other countries. So it's a different epidemiology. Values and preferences, that's important. How much do we value certain outcomes? And that's cultural specific. The resources, we know that cost and cost effectiveness varies by context. Feasibility will vary also by context. The acceptability of the intervention will vary by context, and the impact on health equity. So the ETD, which we reviewed last time, but I'll come back to today, will help you being explicit about these factors and consider how they change from setting to another, or actually from the source setting to our setting, and how that change, if any, could affect the recommendation. Any questions so far, just to make sure that things are clear and to address any clarification questions? Yes, I'm seeing some of the comments. Thank you again. The local health systems, applicability. Yes, the term context sensitive is an important term. We have to judge which recommendation is context sensitive, and this will help us prioritize in terms of what to adapt. And improve outcomes by immediately using the guidelines. Yes, definitely. Patients' outcomes. Okay, thank you for interacting. So this was kind of the background. Now we get to another concept that is important to be familiar with, which is adaptation pathways, which talks about the starting point of adaptation. This is taken from a guidance from the GRADE working group that will be coming out soon about grade development. So what do we mean by adaptation pathways? It refers to how we start the process of adaptation. And as you see, there are 3 pathways. The first one is when you select a guideline first. This is the case of the example I gave you, where the Saudi Society of Rheumatology identified a guideline that is well known to be of high quality. They knew it was on the way. They knew that ACR, the American Society, would be willing to collaborate. And that's another aspect we could discuss maybe during the Q&A part. How willing is the source organization to collaborate? So they identified the guideline and said, okay, as soon as it is published, we'll take it, the whole guideline, and work on it. In some other cases, it's locally you prioritize questions and then you go and look for a guideline. And the third one is the map. I'll talk more about the map a bit later. So as I said, guideline selected first, you select the priority guideline. In our example, it was ACR. You go into ACR and you prioritize questions within their document. And if needed, you identify other sources, but typically you are focused on that document. The second one, questions prioritized first. You come up with your own questions before looking at any guideline. you might have some guidelines in mind. But then the key issue is that after you prioritize your questions, you identify what guidelines are out there, which means that potentially for your set of prioritized questions, you might need to adapt recommendations from 2 or 3, potentially more guidelines. And the third one is something that you might be aware of, a new trend in guideline development, which is mapping recommendations. There's so far 2 maps. I'll show you, I'll give you links to those, where people have mapped all the recommendations on a subject that you go to the map and then search for specific recommendations. So this is the example, first example on of grade development, which was done in Latin America to adapt the American Society of Hematology guidelines for venous thromboembolisms. So they specifically focused on a specific guideline. So they selected the guideline first, and then they say the selection of the specific guideline was informed by priorities expressed by the Latin American partner societies and the status and publication timeframes of the source guideline. This is why they chose this. And this is how they prioritize questions within that guideline. So they prioritize questions that commonly arise in practice, uncertainty in practice with regard of the management, there's new research to consider, there's variation in practice, and there are important consequences for is associated with high resources or cost. So here kind of saying these are context-sensitive questions. Now, the systematic map I mentioned are these 2. There's one for COVID-19, another one for tuberculosis guidelines produced by WHO, and these are the maps. So, Dr. Besma, you're asking how can we get the record? Which record? Are you referring to this presentation? So you could answer the chat. So these are the 2 maps. So this is an example of one map, the COVID-19 recommendations. So you could look for the map, you could search it, you could look at the list, and you could look for some plain language recommendations. So this is an example of how this is mapped. You might say COVID-19, I'm interested in, for example, vaccination for children. So here you go and you see that there's 126 recommendations on vaccination for children. So you could dig deeper and then explore them. So these are the 3 pathways. Again, the 3 pathways, either to start with selecting a guideline and prioritizing a question within that guideline. The second is prioritizing your questions and then looking for different guidelines or using this map. Now, irrespective of the pathway, there's a need to choose a guideline to use in the adaptation process. So meaning that you have to decide which guideline to use, whether you start with the guideline in the first pathway or get to that guideline in the second pathway. And what do you do, or how do you choose if you identify more than one guideline? So how to choose? So this is where the concept of adaptability comes in, meaning that we would like to choose the guideline that is most adaptable. So what does this mean? Guideline adaptability is defined as the extent to which the adaptation of the source guideline to a planned guideline project requires less resources and allows a better contextualization. And my question to you, what characteristics increase the adaptability of a source guideline? So what would be the characteristic of a source guideline that would make it more adaptable than another guideline? So based on our experience, so what factors or what characteristics have you assessed before deciding to adapt a guideline? Or if you haven't, what comes to mind? Okay, thanks, Dr. Yasser. High quality clinical practice guideline as per agree to appraisal using the grade system. Okay, thank you. We need to evaluate the guideline using agree. Thank you. Yes, so this is consistent. Yes, the context. So Dr. Rasme, if you have any further comments on this, we'll be interested in that. High sort of recommendations. Yes, flexibility and feasibility. Okay, good. Less resources, frequent use of guideline. Okay. Yes, I think what you've shared is you're going to see on the next slide. So these are what we think are factors that are important for guideline adaptability. So the relevance of the adaptation project, I think someone refers to the context, is this relevant to our context? The quality of the guideline, people have also referred to this. Up-to-dateness, is it updated enough? Whether the source guideline was developed, use grade, and the last point is clarity on how contextual factors affected the source recommendation. So let me go through these one by one. So relevance of the adaptation project refers to the overall objective of the guideline, the target audience, the health questions covered, and the outcomes considered. So how is this important? Imagine that you are developing a guideline for reducing infection related to IV lines. In hospitals, people use IV lines, and unfortunately, what happens is that there's a risk of infection, and nowadays we have lots of antimicrobial resistant agents or bacteria that get infected. So there's a major effort. And if you think about a guideline to reduce those infections, the target audience could be either the nursing staff or could be the physicians. The physicians, maybe the focus might be on when to ask for a line and when to ask for which type of line, etc. That might be the focus when the guideline targets physicians. When the guideline targets nurses, it might be more about how to insert, how frequently to change, the dressing, etc. So if you are interested in one or the other audience, you have to assess which audience the guideline you've identified, which on the face of it might seem to match exactly what you want. Which one is there? Another example is the health questions covered. So you might be interested, irrespective of the audience, let's say the audience are public health agents deciding on whether to vaccinate people for COVID-19. You might be interested in the pediatric population because you work in a pediatric hospital. And what you find is a guideline on adult vaccination. You have to make a judgment. Is this relevant to me or not? Same issue with the outcomes. So we see this frequently. In some cases, the same guideline that matches in terms of objective, target audience, and health questions covered. So same questions, everything is the same. But the source guideline did not address an important outcome we are interested in. Maybe the source guideline was focused on transmission of COVID-19 as an outcome. In our setting, for some political mandate or some other reason, we're interested on whether it affects mortality, whether it affects the healthcare system capacity to respond. So that's also important, and that might be important in some cases to assess the adaptability. Yes, so health question PICO approach is helpful, yes, because if they've done the PICOs and then we have our own PICOs, we could try to match them. As Dr. Yasser is saying, we need similar clinical questions. Okay, yes, the economic part, sometimes we could deal with this as part of the adaptation, as we will see. But if you have guidelines that are equal in all respects, except that one is coming from a similar healthcare setting, I would definitely go for that. Okay. So this is a key factor. So when we talk about guideline adaptability, the relevance is a key factor, meaning that it might be a deal breaker. If it's a different focus, then I might not use that guideline. And we say here it's not easily remediable because some of these factors you could find a way to compensate. This one is totally off in terms of matching our interests. It's really hard to remediate for that. Now, the second factor is the quality of the guideline, and we had many comments about this. It has to be good quality guideline to adapt. Otherwise, if it's bad quality guideline, you end up with bad recommendations, even if you've done the best job at adaptation, because the base is not a good one. So how do you assess quality of guideline? You measure it using the agree-to score, as people have mentioned, particularly the domains of rigor of the development and editorial independence. These are really key to assessing the quality. So this is a key factor, and it's not remediable in the sense that if you find low quality guideline, it's really hard to fix it, so you can then adapt it. So this is a case where you probably need to skip that guideline, and you might end up developing your own guideline. It might be better to develop your own guidelines as opposed to relying on low quality guidelines. The third factor was up-to-dateness, meaning that, when was it published? When was the search done? We say here whether potentially consequential evidence on the health effects has emerged since the literature search was conducted for the source guideline. So what this sentence is saying, two things, I would say. One, the reference point about whether it's up to date or not is not the date of publication of the guideline. It's the date when the literature search for that guideline was conducted, which might be much older. That's one. And then the term potentially consequential evidence, because there's a guideline that has been published. I identify few studies that have been published after this guideline had the search done. But then if those studies are smaller studies, high risk of bias, and I look at them and they will not affect the results, I think that's probably okay. We don't have to worry too much. I would worry if there's potentially consequential evidence that has emerged since then, because that might change the evidence, the certainty, and potentially the recommendation itself. Just looking at, I'll come back to Dr. Basma's question, just to finish this slide. So the up-to-dateness depends on how much time elapsed since the literature search and how hot the topic is. So how hot? COVID-19 was very hot during the pandemic. It might be less hot now. Some other fields are less hot. So the more you go to rare diseases or diseases that are not, topical, the literature might not generate a lot. So this is a key factor. Again, it is remediable in the sense that if the search is a bit outdated, what we do, we update the search and we identify if there are any new studies. And I mentioned that this is what we practically did with the Saudi guideline adaptation. And we did find one study. It ended up not being consequential. Now there's a question by Dr. Basma. Can we use the grade system to determine the quality of published paper aside from type of design? I mean, we can use it to determine the quality of clinical trials, cohort case. Yes, so the grade system, one of the factors that go into assessing the certainty of the evidence is the risk of bias, so otherwise known as the quality of the study. So the risk of bias, and there are risk of bias tools to assess those different study designs. What I'm referring to here when we talk about, and go back, here we have identified not individual studies, but we have identified a whole guideline, and we're trying to assess whether the whole guideline is of good quality and whether we could use it as the base for the adaptation. So and grade is not designed to assess the guideline itself. A grade tool is. Okay, this is the next factor in terms of adaptability. The question is whether the source guideline developed using grade for certainty of evidence and whether grade tables are available. The reason for this is, so grade is potentially, or not potentially, is currently the most widely used methodology for guideline adaptation. and many of the organizations use it. And the most recent methodologies for adaptations take grade into account. So it would be hard to adapt a guideline that did not use grade. And grade has a major advantage is that it was, as I said, it was designed to increase efficiency and contextualizations by working on the contextual factors. So the last factor or question is about clarity on how contextual factors affected the source recommendation. Meaning what? Meaning that it's important for the guideline group that is trying to adapt to understand how the direction and strength of the recommendation in the source guideline was affected by contextual factors. For example, the source recommendation might be that, and I'll give a hypothetical example referring to a specific medication A. You might have a conditional recommendation. And the conditional recommendation, meaning that it's not a strong recommendation, it's conditional. There could be two scenarios. Scenario one, the certainty of the evidence was low. We're not sure about the benefits. We're not sure about the harms of that medication. And then the panel ended up deciding on a conditional recommendation. So when you adapt, if you are stuck with that same quality of the evidence, you would probably end up keeping the recommendation conditional. Scenario two, let's think about scenario two. Scenario two, the source guideline identifies high certainty evidence showing benefits of the intervention and minimal harms. So that's good. So in terms of balance of benefits and harms, that's in favor of the intervention. However, they went for a conditional recommendation because it's very expensive. So the conditional recommendation reflects the need to ensure that the resources are available, but otherwise there's no concern. And the second one, if in your setting, for some reason, the medication is cheap because you have a local company that manufactures the drug, let's say, then you could easily go from the conditional recommendation in the source guideline to a strong recommendation. So see, there are two scenarios where you end up adapting in a different way simply because you knew how the source guideline thought about this and the reason why they went for a conditional recommendation. So this is why it's important to have a clarity on how the contextual factors affected the source recommendation, because now you could take it to the next step and consider the contextual factor in your setting in changing the recommendation. So this slide, again, lists the factors that affect the adaptability of a guideline, which are the relevance to the adaptation project, the quality of the guideline, the up-to-dateness, whether the source guideline developed using grade, and the clarity on how contextual factor affected the source recommendation. You know, one of the other factors that one could add is, and I mentioned this a bit earlier, whether the source organization is willing to work with you. And I'll give you two quick examples. The example is the one we discussed earlier about ACR and SSA. The ACR, the American College of Rheumatology, were open to first allow the local society or the national society to adapt their guideline. They did not mind. They even shared the material. So all the data, the grade profiles, the systematic review documents, they were willing to share them with the adapting organization. There's another example I'm very familiar with. A few years ago, a Norwegian group wanted to adapt a guideline from a US group. I think it was the American College of Chest Physicians at that time. And when they decided to adapt it, the US society, they knew about it and they filed a lawsuit against the Norwegian group because they felt this is intellectual property, we should not adapt. So it was a big deal. So there were courts involved in this. So you see, there's a spectrum of organizations in terms of allowing others to adapt their guideline. That's something probably to keep in mind and to check with that source organization about whether they are willing to allow this. But if they are willing, the next level, are they willing to share some of these data I mentioned earlier? So a final note is that you have to assess whether the work to improve the adaptability of the guideline, for example, updating the literature searches, would be better spent to develop your own guideline. And again, we've had examples where in order to quote unquote fix the source guideline because they need to update or do some other work, you would think my time would be better spent developing my own guideline. So thank you so much. This was the first part of my presentation. I'll hand it back to Dr. Mernaz.
Thank you so much, Ali. It was a great presentation. So now we have a bit time. I want to open the floor for any question and answer. And also, I would like to invite Dr. Lubna Ansari, who is a professor and chair of the Guideline Steering Committee in King Saud University Medical City in Saudi Arabia, for your kind remarks, and also please share with us, your experience and knowledge. Thank you. Thank you so much, Dr. Ansari.
Thank you very much, Dr. Mernaz, and thanks for Professor Akil for his wonderful presentation lecture. And I like what he has presented. It's logical, it's scientific, it's wonderful from all aspects. So it's really great. Our experience is, and I'll share briefly what is our experience and why we couldn't comply 100% with what Eli was talking about. What we did is that we followed the adaptation, the ADAPT framework, and but when it comes to updating the evidence and using the grade, we haven't done this. But we do the search, we do the critical appraisal of the source guidelines, and we do a kind of contextualization with the experts, and then we finalize the recommendations and finalize the guideline as a whole. The reason why we haven't been engaged very much in this is that we have so many groups. So we have the steering group, and we have like 20, now they are coming up to be 22 departmental groups which are working, which are doing their own guidelines, and we were supporting and endorsing the final product, but we don't have the capacity in order to do a systematic review for each, for at least some of the recommendations for each of the working group that we have, and we didn't have. We don't have those who are trained in grade. There are a few of us who can handle these aspects of guideline development in the way that was described by Professor Akil. So in general, it was productive, or it was useful in the sense that it has shown our method that there is an impact and there has been an improvement in many KPIs or outcomes. So we thought that it is good or very good, but it is not excellent. If we are describing what Eli has just described as excellent, and we thought we don't want to, that proverb, don't let the excellent be the enemy of the good, something like this, or the perfect. But I think there is a room for improvement in our setting and in the region as well, and that can be led by WHO EMRO, and I'm really grateful by the work that Dr. Mernaz Kharandish and Dr. Professor Arash Rashidian are doing in the region. I think that's fantastic. But what we need is to, through the evidence to policy framework, to emphasize more on the need for capacity building in terms of systematic reviewing and in terms of grade practice and grade implementation throughout the process of guideline development. I think with that we can complement and support our region. I'll probably stop here, and thank you very much, Dr. Mernaz, for the invitation.
Thank you so much, Dr. Lubna. That's the very valid comment that you said. That's the problem that we have. I mean, colleagues, you're here. I mean, I hope that we have also colleagues from Egypt. You can just jump in and share with us your experience in Egypt, that we recently started to establish the national program within the Ministry of Health for Egypt to have an integrated system for adaptation of guidelines to the country context. And as you said, that the issue that we have is the kind of technical capacity in terms of doing the systematic reviews and using the GRADE methodology and approaches for doing these kind of things. And so that's really true. And we need to have some more, capacity building in these regards. And I just want to also maybe here announce that, that we have planned for a kind of longer sessions next year to go through some details, to discuss in depth about the methodology of some of using of these approaches, and also these kind of methods for guide adaptation. So this is something that will happen. I mean, again, we will have it, as kind of virtual workshops to have colleagues as much as possible, and also to be able to share the recordings for who cannot attend these workshops. But this is very valid, suggestions. So I also, I mean, there is a comment, again, thank you, Dr. Lubna, thank you so much. So there is another comment, Ellie, I think it was from, okay, so you have replied in chat box. If you want to add a few sentences to what you have written in chat box, please, over to you, Ellie.
Yeah, thank you. If I may first just comment on what Dr. Lubna mentioned, which is the importance of efforts in the region. I think, we've had many experiences where we had people from outside the region come and, help us with guidelines. And, it's really important to develop the regional capacity, but also the national capacity. It's not just regional, it's also national. So you could have your own capacity and then you become independent. But that requires probably two things. First, institutionalizing the process and not being based on initiatives from societies or groups, having an entity at the national level, whether governmental or not, but having an entity that is in charge of developing recommendations. I think that's important. And then building the local capacity, which is not easy. It takes a lot of time and effort and investment and commitment. But I think we can do it, and we have some very good examples from the region. Just we need to make this more common. And I think the efforts by EMBRO at this point are in line with that. So this is really important. So that's the first one. The question by Dr. Ghada was about whether we could use adapting from more than one guideline. And just to say that the reason we have different pathways is because the different pathways meet different needs. Sometimes you have an excellent guideline where you say, this is it, I'm just gonna work on it. Sometimes you do have your own questions that you will not find in one guideline, then you need to chase different guidelines. And there are pros and cons. You have to decide on which one to go for. Yeah, but it's both of these, or the three pathways are reasonable.
Thank you so much, Eli. I just want to also share a kind of recent experience that we had during COVID-19 pandemic. I mean, in the region, we tried to assess some of the national treatment. Oh, sorry, I think I was muted, so sorry for that. I was saying that, I also want to share a kind of recent experience. I don't know who is just trying to mute me. Colleagues, sorry. Yeah. So sorry for this glitch. So I mean, I was saying that I want also to share a kind of one of our recent experience, regarding having some, we did a kind of assessment. We assessed about 10 national treatment guidelines during COVID-19. I mean, the guidelines on COVID-19 to treat patients with COVID-19 in the region. I mean, 10 guidelines from 10 countries. So, and that also showed us that how much is important, not just to adapt guidelines and recommendations to the context, also to use the robust methodology for doing that. I mean, there were some adapted guidelines. I mean, I can say that, out of that 10 guidelines, about 7 of them were adapted guidelines. But unfortunately, the approaches and the methodology, used for that adaptation was resulted in having some guidelines and recommendation that was opposite not only WHO, also the recent evidence on COVID-19, treating patients. So, and that was kind of for us, again, another, I can say, warning note that we do need to have some more works on the technical capacity building for using the robust methodology, and not just emphasizing that we need to adapt the guidelines, but we need to also know that what are the processes, what is the methodology for doing that, to have a valid recommendation at the end to be used, and to not misdirect and misguide the policies and policy direction. So this is very important. I see also Dr. Rasma here, that we had also another experience with Ministry of Health Qatar in adapting, and this is also the work that also is done by guidance and collaboration of Dr. Lubna Ansari and her great team from King Saud University, to adapt some guidelines to the national context for Qatar. And I thought that maybe Dr. Bushra and Dr. Rasma, you want to also share some experience regarding that project with us.
Okay, Assalamu alaikum. Thank you, Dr. Mehrnaz, for this opportunity. Yes, we have the pleasure and the honor to work with Dr. Lubna and yourself to develop the national clinical guideline for non-specific neck pain. That is part of our clinical guideline programs. Till this time, we have 54 national clinical guidelines that are published in Ministry of Health website in Qatar. It has been a very productive, and we have learned a lot and from Dr. Lubna over the last 18 months working on this guideline, and we look forward to work on the implementation, because having the guideline, as you know, Dr. Mehrnaz and other colleagues, having the guideline developed or adapted and developed and published is part of the work to serve the purpose the guideline have been developed for. So we want also through this platform and from this initiative to call for a more collaboration and more capacity building in developing the capacity and building the capacity in the region, and the implementation of the guideline and monitoring of the guideline. Yeah, it was a very, very successful experience, and we look hopefully the neck pain guideline will be published soon, along with other guidelines that we already developed through this program. Thank you again, Dr. Mehrnaz, for this opportunity, and we are here to support and to share our experience and to contribute in any activity to learn more and to share, and even to support other countries in the region and what has been achieved through our program. Thank you, Dr. Mehrnaz.
Thank you so much, Dr. Rasma, for your intervention. So I also want to mention that, because Dr. Eli and Dr. Lubna, we have great experts in our region. We have you both, at least. We have experts here, and I think that with your guidance and with your support, we can really enhance this program in the region. We had a technical presentation regarding guideline adaptation, having national program for guideline in the regional committee just in October this year. And we received many positive feedback from ministries of health here from the 22 countries in the region, which is also a very good opportunity for us to working together and to enhance this capacity. And we think that through what we are doing for Egypt, that you both also, Eli, he's supporting us also for that purpose. I think that, very soon we will have an integrated system as a kind of role model in our region in Egypt, which has a systematic approach, as also Eli mentioned, for adapting guidelines to the national context, not as having a kind of fragmented system, but as having an integrated system for doing that. So I saw some messages in the chat box. The presentations for the previous, yes, Dr. Lubna, please.
Wanted to say something. You have both of us here, but we work in teams. So I have a great team, and I'm sure Eli does as well. Dr. Yasser Amir and Dr. Ghada Bawazir are here from our team, and I'm sure that I can see many names that I know from Eli's team as well. But what I wanted really to say is that the role of WHO EMRO and what you are doing, Dr. Mehrnaz, is wonderful. The gesture of both of us, of our team working with the Dr. Rasma and her team was wonderful. We somehow, and I'll talk here frankly, because we are all from the same region, we know how to work with international people. We know how to, not me, people from our countries, they know how to contact McMaster University, they know how to contact others, but we don't know how to work together. And maybe that role can be magnificently done by WHO EMRO in making us really accept and work and learn from each other. Thank you very much.
Thank you so much. Thank you, Dr. Lubna. Anything from your side, Eli, to add to this recent discussion?
No, just to agree with Dr. Lubna about what she said. We have expertise, and just to give you an example in terms of the expertise in the region, it happens that both Dr. Lubna and myself are on the board of the Guidelines International Network, which is really interesting, two individuals from the same region on representing that board of this internationally leading organizations and guidelines. Dr. Yasser also has a leading role within GIN. So this is just an acknowledgement by the international community of how much expertise we have in the region. It's just about us working together. And I think having EMRO lead the way is really important.
Thank you so much, Dr. Lubna and Dr. Eli, for your kind words. And just one thing, before going to 5 minutes break, that we put the slides for our previous workshop on great methodology on chat box, and Malika, she did, and the presentations for today's session also will be shared with you at the final minutes of this session. And for the recordings, I put in the chat box the link, which is the link for our team, which is the evidence and data to policy team within WHO EMRO. There is a page, there is an icon for capacity building that you can find all of our recordings and materials relevant to our courses, workshops, and training, not only for guideline, for other topics, such as, for example, policy briefs and other, workshops that we had relevant to evidence-informed policymaking, and you can find all of them there. But the recordings of this workshop series will be uploaded very soon. It's not uploaded yet. We are working on the recordings. You know that we need to fix them, to cut some points, which is not, of course, interesting to people who will see it later. So they will be ready very soon, and we will upload them. We will upload them on the web page very soon. So I think with this we can go for 5 minutes break, if you agree. Okay. So colleagues, we will have 5 minutes break, and then we'll see you soon again here. Thank you. Hi again, colleagues. And Dr. Eli, if you're here, I think that, we can continue the session.
Okay.
I mean, I know that 5 minutes is very short. Sorry for that, but the whole session is very short. We have just 3 hours to go to all discussions and sessions. So colleagues, hi again. So we will continue the session again with the second presentation from Dr. Eli Akl. Thank you, Dr. Eli. Please, over to you.
Thank you. So thank you again. And I think the discussions we are having are as important as this, the presentation. So I hope we can continue to engage in those discussions. So if at any point, anyone who has anything to add or maybe ask a question or to share their experience, please feel free to do so. Thank you. So the second part is about the grade development methodology. So in the first part, we discussed the concept of adaptation and its importance for both efficiency and contextualization, discuss a little bit the different frameworks. So here we focus on one of the frameworks that we have been developing as part of the grade working group. So we've already said this, that the goals are the efficient use of existing guidelines and systematic reviews and the contextualization. And I mentioned earlier that grade development was specifically designed to achieve these two goals. So just as a historical background, and that's another thing I think we should be proud of, that the grade development has been developed through work in the region to adapt guidelines for the Ministry of Health in Saudi Arabia. The development, and I mentioned this a bit earlier, combines the options of adoption. So some of the recommendations, you use them as is. Adaptation, you take through the process of contextualization and exploring the local context, or in some cases, you develop your own recommendation because they have not been addressed by the existing guidelines. So I'll come back to this in detail, but this is a quick overview of a grade development approach, the newer version. This has been approved by the grade working group, and hopefully it will be published soon. But to go into a bit more details, so keep in mind, or a reminder about the different adaptation pathways, and one could get into development using any of those pathways. So one is choosing the guideline first, and then prioritizing questions within the guideline. Second, prioritizing your own questions first, and then looking for guidelines that answer these questions. And we've had a discussion in the chat that this could be a reasonable option when it fits the purpose. And the third one that is currently less used is the use of the maps. But once you have decided on which pathway you take, this is how you enter the development process. And this is a representation of the first pathway. Again, select the topic, prioritize the questions, and then this is second pathway actually, and then identify appropriate source guidelines. And here you will see that these are some of the criteria we discuss about adaptability. So it has to be relevant to your subject. The source guideline has to be credible. Assessing agreed to tool, for example, has to be relatively recent, so that's up-to-dateness. And ideally use the grade approach because it would make your life much easier. And I'll give you some example of why is that. So once you have done this, you get to the point where you have identified the guideline, and then you match the source guideline to your questions. For this question that I have, what is the recommendation that addresses it? Now, if there is a matching question, we go through the process. I will come back to this later. If not, this is when you do your own de novo development. So coming up with your own recommendation. So new recommendation. And this is very similar to starting your own guideline. It's just that we're doing it for a very select number of questions within this overall process. Now, back to the case where there are some matching recommendation. In some cases, as we've done in few of our experiences, we would do a quick update of the systematic review to look for any newly published studies. And here's the question, when you update the systematic review, if there is ETD from the source guideline, then you go through the ETD and you reassess the judgment. And that's something I will show you in detail. And the ETD is that list of factors I already mentioned. If no, you have to develop your own ETD, which adds to the complexity of the process. So that's why we're saying if you have a guideline that already uses the ETD, use a grade approach, you've already saved much of the time. Now, what you do is you take this recommendation through the process, and if the recommendation is similar to the source, that's an adopted recommendation. If it's not, it's an adapted recommendation. So this is the list of factors I mentioned, but the main message here is that going back to the concept of efficiency and contextualization, we discussed efficiency a bit. I'm going to focus on contextualization now. So contextual factors are important in guideline development. They become even more important when the certainty of evidence about the health effect is low or very low. Because let's say a drug is expensive, and let's think about, again, two scenarios. So the drug is expensive, but there's very low certainty evidence. We're not sure whether it works. We're not sure about adverse effects. When it's expensive, it's easy to say we're not going to recommend it. We recommend against it. Now, if it's expensive, but then there is high certainty evidence that it works, then the decision becomes more challenging. It could go in favor or against. But then this is an example of where the price becomes a more definitive factor when there's low certainty evidence. High price, low certainty, you could dismiss. And it's not just about the price. It's about acceptability to key stakeholders, feasibility, and affordability. So it's not just about being effective and safe. It's about all of these factors. Because if it's not acceptable, if it's not feasible, or if it's not affordable, and even if it's effective and safe, there would be challenges with implementation and subsequent adherence and expected effect on health outcomes. So now, what do panels do if there are issues with contextual factors? For example, if acceptability varies across settings within the same jurisdiction, or feasibility, and I mentioned in the example I gave during the first session about the availability issue for one of the contextual factors, availability of the same medication, different healthcare systems within the same country. So what can you do? You could include a condition to consider these factors when interpreting the recommendation, meaning that you're kind of saying if it's available in your healthcare system, go for it. If it's not available in your healthcare system, don't go for it. So this condition is linking to the contextual factors and using the contextual factor in order to further interpret the recommendation. And then you have to consider the implication for the implementation, because if you feel that this is definitely something to be recommended, and if it's not available, you might, as part of the implementation, give suggestions on how to make it available, or how to negotiate the price, or how to find ways to have access to that intervention. So now what we're going to do, we're going to spend just for practical purpose a bit of time doing an exercise together. We're going to review how the panel of the source recommendation judge each of the ETD factors. We will reflect on what factors drove the source recommendation, and then we'll consider how the local context is different and how it would modify the recommendation. It sounds too complex, but the best way is just to dive into the exercise. What I will ask you to do is just maybe use the chat box to answer some of those scenarios. So let me do this one more time because I realize not everyone was part of the first workshop. What we explained as part of the first workshop is that the evidence to decision table, which is represented here, represents all important factors. For example, desirable effects, undesirable effects, uncertainty of the evidence. These are all about the health effects. And it also includes the contextual factors: resources required, cost effectiveness, equity, acceptability, and feasibility. And for each one of these, the panel makes a judgment. And based on the judgment, they come up with this recommendation on the right-hand side. So in this scenario, the panel judged the desirable effects to be moderate, which is good. So it's, you know, the options are trivial, small, moderate, and large. So moderate desirable effects, that's good. They judge that the undesirable effects are trivial, which is great. So you have something, an intervention that has moderate benefits with trivial harms, almost no harms. And it is based on moderate certainty evidence, which is, again, good news because we have moderate certainty in those effects. So it's not like we are uncertain with very low certainty evidence. And the panel judged that the balance of effect favors the intervention. So moderate benefits, trivial harms based on moderate certainty evidence. They judged that it favors the intervention. In that case, they had no negligible cost and savings, so cost was not an issue. Cost effectiveness favors that intervention. Equity probably increased with that intervention. Acceptable and feasible. So it made sense then to come up with a strong recommendation. Everything is in favor. Everything is favoring this. So that's in the source guideline. Now imagine that in your setting, you look at this, and you have concerns about feasibility in the local context. So if I'll go back to the previous slide from the source guideline, just to show you the change. So this is the previous slide. When the guideline group adopted, they were fine with all of these. However, they have this at the bottom. Look at the yes at the bottom in terms of feasibility. It moves to not feasible. So they have concerns about feasibility in the local context. And concern about feasibility might be due to, for example, a lack of resources. So if it's an intervention that needs a specific expertise in terms of healthcare workers and we don't have them, then there's feasibility issues. How can you implement it? Or it needs a specific kind of diagnostic machine that is not available. You know, the evidence would still be in favor because the evidence is global. It doesn't change when it comes to the local setting. The cost might not be an issue, and then all the other factors. So my question to you, how would you adopt this recommendation? The source recommendation was strongly in favor. When you analyze the contextual factors, the one thing that changed in your context is feasibility. What kind of recommendation would you give? Would you go for strong recommendation in favor to conditional, or would you even give a recommendation against? So let's think about this together. First, I'm interested in seeing, like, the overall sense, whether people would keep it the same, make it conditional in favor, or make it against. And then maybe we could discuss. So if you could just type what would be the recommendation in your setting. How would you change it, or maybe not change it? And if there are questions about the question, please let me know. I could clarify. Yes, Dr. Savi writes, so the feasibility is key, the feasibility of the intervention, but it was simply not feasible. One example you could think of is, a recommendation for mass vaccination for COVID-19, and then you don't have enough venues, or you don't have enough personnel to implement it. What would you do? So, Dr. Rada, so you would go from strong to conditional. Same with Dr. Sakine. So, conditional in favor still, or against? Conditional, okay. Would anyone like to speak or maybe ask a question about this recommendation?
I just want to ask question, Ellie, here, maybe just to have more discussion here. So, for example, now we know that feasibility is very important. So when we have a good option, but we cannot implement and we cannot use it. So sometimes bringing those in the guideline, but when you cannot use it and you cannot implement it, so why we have this kind of recommendation in the national guideline? But another question is when we talk about adaptation process here. So there is a recommendation, for example, as you mentioned, the recommendation is having deployed these vaccines, in some settings, but in our setting, in our local setting, we cannot go for this kind of different facilities. So could we adapt that recommendation to our context and make it something that it will be feasible for us? Or not? Thank you.
Yeah, thank you. So yeah, interesting question, interesting suggestion. And I think I think we have one thing in common. So thank you for those who also responded in the chat. And I think what is obvious is that people are definitely moving from strong in favor to some, lower kind of recommendation, either condition in favor or condition against, or even strong against. So I think there's a common sense of concern. And then the question becomes, what do we do? Because supposedly this is beneficial, but we have some concerns. So one of them, as you just mentioned, Dr. Mernaz, is that if there are anything to maybe change the way you implement the intervention to make it more feasible, you could think about it, as long as this doesn't affect the supposed efficiency or effectiveness of the intervention. If the way we're implementing it doesn't affect why it is not feasible, or why it is effective, I wanted to say. And yes, so understanding why it's not feasible and could be addressed. For example, let's say there's a need to do some training. So you could say, let's say you give a condition recommendation, and the condition is that the center, let's say different centers might take that recommendation into account. You're kind of saying those centers that are able to build the capacity to implement that intervention can then do it. So it becomes conditional recommendation on improving feasibility. So kind of thing. So, okay, at this point, it's not feasible. However, we condition recommend it. What's the condition? In your center, you build the capacity so it's feasible. Because once it's feasible, we can benefit from the moderate desirable effects and trivial undesirable effects. And Dr. Ghada is saying things may change in the future. And yes, so this is something that people use it, for example, with cost. They give a conditional recommendation based on cost, meaning that if the cost drops, then you should use it. Sometimes when it's a clinical recommendation and the feasibility vary by the person, for me, it might be feasible as opposed to someone else. So if I understand that the only reason for this being conditional is because feasibility, and for me, feasibility is not an issue, then I would go for it. So the conditionality is a signal that, we're saying conditionality because we want to point you to the condition, which is improving feasibility. Okay, so I think that's very good. So I think that was one example. We have two other examples. It would be good to go through them and then reflect further. So this is another example where the recommendation was conditional in favor. So why conditional in favor? So I'd ask you to look at this summary of the judgment, and you tell me why you think that the panel went for first, why in favor, and second, why conditional, not strong in favor. So two questions. Why did they go that in favor of the intervention, and why was it just conditional in favor? Again, this is the source recommendation in this case. So the first question, why do you think that they went in favor? I'm assuming that people are typing, but if anyone would like to use the microphone, please feel free. So the effect is large. Yes, so the effect is large. So this is the reason to go for it. Yes, and the cost is high. Yeah, so Dr. Ghada, it's just this, what I'm showing here is a summary of the judgment on the evidence to decision table. And actually, it's called evidence to decision is because people review the evidence, they make those judgments before making the decision, and the decision is here on the right-hand side, which is conditional in favor. So Dr. Safi is saying due to low grade acceptability and feasibility. So I would say here that, yes, would have liked the acceptability to be yes, and yes, it's probably yes, but that would still kind of say, let's say in favor of the recommendation or the intervention. Dr. Madhu, you have your hand up, please go ahead.
Hi, good afternoon. I'm Dr. Madhvi from Qatar. Thank you for the wonderful presentation and the inputs provided. I have one point actually. Can you please clarify about it? See, these recommendations and all, they are advocating or the guidelines, they are advocating to follow the best practices. At the same time, are there any specific recommendations for measuring the impact, actually global impact or national impact with respect to various programs from the user side, yani patient side?
Yeah. Yes, so I'll address this very briefly, and maybe we could have discussed this in the Q&A section. Unfortunately, that part of the, let's call it the guideline enterprise, is still on the short side. We don't have good ways of assessing implementation. There are quality measures, and you could have metrics and percentage of individuals who comply with this. But I have to say it's not could be developed better, but definitely could be applied better. Just to take, before taking the next hand, saying here that, so Dr. Maitham is saying because of large desirable and moderate certainty evidence, yes, so this is in favor. And the cost, yes, so the cost, as it has been said, this is the reason why they did not go for a strong recommendation, because it had it been low cost or savings, people might have gone for a strong recommendation. Dr. Lubna?
Yeah, well, I used to know a lot about grade that was in the past, but not recently. So I'm refreshing my knowledge about grade now. But I used to have the impression that when a recommendation is labeled as conditional, then it has to do with many factors, but mainly it's the evidence and the uncertainty level. But now when it comes to cost and feasibility, these things are possibly, some people can afford it if it is available. So is there a way in the recommendations where people can find why they were conditional? Or do they have to go through the other supporting documents? I mean, an easy way so that people can, if people can pay and afford it, why not then? Or buy it from outside or whatever. Yeah, thank you.
Thank you. This is, this is really on spot in terms of why this is being, this transparency or being structured, why it's being pushed. Because here, if you look at this, you can tell that it's not strong, not because it's not effective, it's just because in that context, the source guideline, it's expensive. So when I look at this, and let's say I'm well off, I have the money, even in the source context, I have the money, it's not an issue for me, or I have insurance, now I know that I will go for that intervention because it's, the desirable and undesirable effect are in favor and cost is not an issue. Versus the same kind of conditional recommendation, but conditional because the certainty of the evidence is low. Now, it doesn't matter whether I have the money or not. It's just, we really don't know whether it works or not. Even if I have the money, I might still not go for it. So being transparent about the reason for conditionality, whether it's related to the certainty of the evidence or related to the contextual factor, is important. One, for people who are interpreting the recommendation, but two, and this is the point we're trying to make today, it's important for those who are adapting. And let me just go to the exactly, trying to illustrate that point. Let's say that in our context, the prices are lower. So see, I will go back one more time just to show you again how it changed. The same figure, so just everything is the same. I just moved to the right-hand side 2 factors, the resources required and cost effectiveness. In our context, the prices are lower and it becomes cost effective. And we do have examples for this. For example, when new antiviral treatments for hepatitis came out, the cost was crazy in terms of how much people need to pay. But the Egyptian government was able to get, I can't remember, it's about licensing and to be able to manufacture the drug locally. So in Egypt, the cost of the drug dropped down. So if let's say I'm developing, and I know that in my context, this is how the price is different, let me ask everyone the question now, and then we come back to the discussion. What would be the adult recommendation? Would you go for strong in favor, condition in favor, condition against, or strong against? Knowing that the source recommendation was conditional in favor. So Dr. Vahid is saying strong recommendation in favor. Okay, good. Anyone else? Would people agree, disagree? So yes, okay. So Malika is saying the same. Yes, okay. So people are saying the same. So, and yes, that makes sense because now we took into account our context, we took into account the cost, and now it is important. So again, the point is, imagine that all what we had from the source guideline is that we give a condition recommendation in favor of this intervention. And they tell us nothing about why it is a condition recommendation. For us, when we are adapting or adopting, it's really hard to think, okay, what do we do? Versus here, they told us it's conditional because of the price. And we know we collected our own data about the price. So now it's easy for us to modify the recommendation. if it was about the certainty of the evidence, we would have modified it in a different way, or maybe not modified it. So the point from this exercise is to illustrate the importance of us when we are developing, understanding the reasoning behind the source recommendation. So let me give you a third example, and then we could go back to the discussion. So here it's a third example of a conditional recommendation against. So again, let me ask you the question. Why do you think the source guideline went for against and conditional against? So based on their judgments. Yes, Dr. Maitham. Yeah, thank you. So the question, why did they go, does it make sense that they went for conditional against? Yes, so it was conditional against. So what do you think, based on their judgments, what kind of justified them going conditional against? Yes, it's because of small effect. So there's small desirable effect, and then at the same time there's small undesirable effect. So you see, it's a very tight kind of benefit harm. You know, you're benefiting a little bit, but there's still some little bit of undesirable effect. The certainty of evidence was low, so we're really not sure. And then, you know, the cost is not an issue, the equity is not an issue, acceptability, feasibility, they are fine. So the main reason is really this upper part, small and low certainty evidence. So now let me give you this scenario that in your context, you identified emerging evidence that changed the effect estimate and certainty of the evidence. So that's why you see when moving from the previous slide, which is the source, to your own context now, because there's a new evidence that you identified, there's large benefit based on high certainty evidence. And practically, this also pushed the cost effectiveness to come to the right-hand side. So all of these change to the right-hand side. The benefit, the high certainty, the balance is now favors the intervention, and even the cost effectiveness is favored the intervention. So let's do this one last time with this exercise. What would be your adult recommendation? Would you change it? And if yes, to what?
But Ellie, I have a kind of issue and challenge for the source guideline, because we have another option in the country, which seems in terms of the effects and the value, it's not different from this new one. And even the new one, the acceptability and feasibility is probably yes, is not definitely yes. So in that case, why we will go for a kind of conditional against? Why we are not saying that it's against? And, you know, because should we always have, a kind of very, undesirable effects or very large desirable effects to just say, for example, yes or no?
So you mean have gone for strong against?
Yeah, based on this, because if I have a better option in my country, which is, acceptable and accessible and affordable, feasible, so why I'm going to include something which I have doubts about this acceptability and feasibility, while it's not going to add, effects. So
I think that, I think that's totally reasonable. And another panel might have exactly done this. They say, this is an intervention where we have low certainty evidence. We know nothing about benefits and harms, or at least our guess is they are small. We're just going to recommend against. And different panels might do it different ways. And both of these, conditional against and strong against, could be justified in this case. It will depend on the context. If you are in a context where you want to give some leeway, so let's say there's no other, and I think your example is really good. If there's no other alternatives of treatments for these patients, you might still want to give some room for use just in case. Let's say this is in an area where there's many effective treatment. Let's think about cancer and many effective chemotherapy. I would just say no, forget about this until we have more data. It could have been that, you know, this is the only option that is available and they didn't want to rule it out. So it's interesting that with the same kind of judgment, two different panels will come up with slightly different recommendations, which is fine as long as they justify why, so the reader and the user understand why. Now, going back to this, it's interesting that everyone who answered said in favor, strongly in favor, going from conditional against strongly in favor because there's a new data that has emerged. Again, this shows the importance of understanding what changes in terms of factor and how to interpret that. And in order to know what changes, we need to know what were the original judgment. And I think, you know, probably this example, I would say, is the best example. Also going back to Dr. Lubna's point, you know, understanding, you know, the reason why they went for conditional and then making our own judgment in our context, how this might be different, will make it much easier to come up with decide on the adult recommendations. So so let me stop here. And has this exercise helped you understand that the importance of this detailed assessment of the judgments, not just for the interpretation of the recommendation for those who are looking at the source recommendation, but also to understand how to adopt or adapt? And do you have any further thoughts about this? And we can come back to this. Yes, anyone?
Yeah, just if I may, I mean, it's an eye-opener that even if it is conditional, you need to look at the evidence, because you might come up with a totally different recommendation, which is not very nice thing to, it might be practical, but it is not time saving, but it's, so you need to go to the evidence, still refer to your evidence tables. Thank you.
Thank you. And actually we had, you know, I have to say this is not common, at least in my experience, that you have identified, compared with the previous guideline, new evidence that is kind of changing the certainty. But we've had, you know, I have in my mind at least one example where between the publication of the source guideline and our work on adaptation, there was a new study, large study, well done, that changed the effect. And then the developing guideline panel made a totally different recommendation. And it was more up to date than the source recommendation. And then the question is how efficient to do it every time, to update the systematic review. It could be not efficient, because especially if you have a lot of questions. So this is why it's ideal to adapt the recommendation as shortly as possible after the source guideline. So we're not trapped in that kind of the need to update, because if we're doing it a few months later, we might just skip the updating because we trust that it's during this period, hopefully nothing was published. The other thing is to find efficient ways of kind of updating or identifying new studies. What people are doing commonly is asking the experts, simply asking the experts, are you aware of a new study that came out? Because in a specific field, the expert would know what's new in that area. And there's a groundbreaking trial, they would have probably been aware of it. Hoping that artificial intelligence and some new techniques would also help with that. So let's talk about quickly some practical aspects. If you remember, we discussed the last time, and I showed this as a reminder at the beginning of this workshop, how to use this evidence decision table in the Grade Pro. So you have the acceptability here, there's the research evidence, and the original panel judged it as yes. When you do the adaptation or development, the software will show you what the original panel did, and then you ask your own panel to add any additional information and then make their own judgment. Here it happened that for the acceptability factor, the panel decided to go from yes in the original guideline to varies, because in their context, they're talking about all these reasons why acceptability varies. And they changed it. So what that software does is that you go through each of those factors and judge whether you have a different judgment. The default is for you to say the judgment for acceptability, let's say it's the same, etc., and then clarify which ones are different. So here is a summary that shows that, for example, for all of these factors, the panel decided that it's the same, the same judgment. They just had some changes for some of these factors. So they checked as these varies for many of those factors because their setting was very kind of heterogeneous. And then also as part of that, what we call the development module in Grade Pro, they look at the original recommendation and then they decide whether to change it or not. So in this case, they did not change it. And this is the original recommendation as written by the guideline, source guideline. This is how it was written by the developing guideline. And you'll see here that the remarks are much more detailed, which is good. So now, in the last 2 minutes, I'm just going to cover a few lessons learned in terms of our experience in development in the region. So what's been successful are the different types of guideline developers that have been engaged with governmental supported, professional network, professional societies. And for all of these, the methodology has been acceptable and feasible. So local decision makers and practitioners have been able to prioritize their own questions, and we've come up with different ways of identifying what are the context sensitive questions, and this is important, and this is really important for the local stakeholders to be engaged. And then the grade about development is flexible because you have different entry points, as we said about the pathways. If the ETD is available, that's good. You could build on it. If it's not available, you could develop your own ETD for the clarity of the process. What's been also good is the collaboration with the source guideline developers. We discussed this a little bit, and the importance of always checking with the source guideline, whether they mind first, because you don't want to get trapped with people who are obsessed with their guideline and not wanting anyone to work on them. But also it might be a potential opportunity for them to give you the data that you need. And, the use of the software tools has been very useful because it helps facilitate the work. So improvement opportunities is better integration of different activities within the health decision-making ecosystem. So guidelines with health technology assessment, with quality improvement, and we've had questions about implementation and how to measure it. So this needs better work, better engagement of stakeholders, because that increases the ownership and uptake. But hopefully with more awareness and the work that different groups are doing in the region, this will improve, and better linkage to implementation. Assessment of uptake and impact. And the other issue is sustainability. We discussed a little bit the importance of institutionalizing the process of guideline adaptation. And as soon as you start having institutions, that will be key in terms of maintaining this process, ensuring there's adequate capacity building. And you always need the champions to lead and sustain the work. And we've had good examples in the region in that. We need more of those examples. So to conclude, development and adaptation in general is not only about saving time and resources. So this is key, but as we've seen from the example, it brings contextualization to the center of the recommendation development to facilitate the later implementation. It should never be just about saving time. it should be about contextualizing, and whatever information from the context that is needed for that should be collected. So I'll stop here and thank you for your attention.
Thank you. Thank you so much, Eli, for, I can say, fantastic technical and interactive session. And thank you all colleagues, participants, for your active collaboration to this, in the discussions. So now I want to invite our next presenter, who is Dr. Arash Rashidian, Director of Science, Information and Dissemination in WHO EMRO. And I think that Dr. Arash, you will also cover and address a part of what Eli just mentioned now in the lessons, in his lesson learned, that we need to have integrated system, having a kind of multi-concept approach, bringing all together these technical programs and these sources of evidence together to have better and efficient, more efficient decision-making processes. So I think that you will cover also this item in your discussion. So floor is yours, Dr. Arash. Thank you.
Yeah. Many thanks, Dr. Ferendish, and many thanks to Dr. Akil. So hello, everyone. So good afternoon or good morning, depending where you are. It's a pleasure to be with you, and I apologize for joining late in the session. I would have loved to be from the start. I listened to the final slides of Eli earlier, but I didn't manage to be on all of it. I'm in a duty travel, so joining not from my office, but during my travel for another purpose. So I think, as Mehna said, I mean, what I'm going to talk about will follow nicely where Eli ended his talk. And let me just making sure I have the correct window shared, and then I will start. Can you see my window?
Yes, we can. Just put in the slide mode, please. Thank you.
Okay, very good.
Okay, thank you.
So given the nature of the discussion, and definitely because of the detailed discussion I'm sure Eli has had in the process, discussing about the methods and approaches that need to be followed, and in particular focusing on how grade development process works for adaptation of guidelines, my focus is more about the wider issue of the context. Obviously, I will refer back to the steps in the end. So the minimum things that should be embedded within any adaptation guideline, national guideline program that focuses on adaptation at least. But then also the process of how the sort of the national ecosystem for evidence-informed policymaking and the national guideline program should work. So as I mentioned, I will refer to a few, quick things. One, just highlighting the WHO agenda in support of national guideline program. And just checking with you, Mehnaz, did you cover this at the start?
No, I didn't. Please.
Okay, very good. So I will say a few words on that. Then the key specifications, that if you call something a national guideline program, so what are the minimum key specifications for such a program, and then roles and responsibilities in different areas of adaptation process. So, I mean, some of you have attended previous workshops, and you are probably aware of the this slide and what I'm showing here. But then, in a way, as we heard also from Eli, it's absolutely important to ensure that different programs that are aimed as use of evidence from research and data in national decision-making, national policy-making, or talking to each other. In our region, I'm proud to say, I mean, the region made a very important decision in 2019, probably the first approach towards this integrated process to bring all different programs together, not only guidelines and health technology assessment programs, but also the knowledge translation processes for higher level policy making, and then the use of data from different sources, the way that they feed into different programs. We know data, national data has a key role in development of guideline recommendations. Also, obviously, in the development of health technology assessment reports, and also what they may or may not recommend in terms of the next step in national policies. But again, sort of not necessarily in every country that there are adequate links between this agenda, these programs, and also definitely the case, not adequate expertise and resource availability to ensure these work properly. So in 2019, when the ministers made that decision, among the decisions that they adopted was this statement that countries or member states, as they call it in the WHO language, were recommended, and they agreed, and they made this recommendation to themselves to establish national programs to adapt and or develop evidence-based public health and clinical practice guidelines on national priority issues. So this series of workshops that currently happening, and the program that we are doing in the region is actually in response to this decision of the Minister's Office of the region. I'm sure, I don't need to repeat this, but a quick reflection of the national guideline programs are needed, not just because of, for example, the benefits of each individual guideline itself, but they provide a sort of a credibility for the main recommendations that the country makes for enhancing public health and clinical decisions. Obviously, that credibility coming if the program has a good basis, follows methodology that is correct, and manages the biases that may occur because of using not proper evidence, but also biases that they may occur because of the stakeholder interest. So let's say if a group of physicians or other healthcare professionals that develop a guideline and they don't engage all the stakeholders, the recommendation may bring aspects into it which are more sort of in line of the views of that group of healthcare professionals rather than the other. So one specialty against the other, or let's say doctors and nurses, or different levels of care, etc. So in a way, when the national guidelines are established, if they do all the processes better, they actually support the position and decision that should be made. National guideline programs, by involving stakeholders, they enhance also ownership, the national ownership of the recommendation. So it's not the sort of a decision that the Ministry of Health made by the officers sitting in the ministry, is actually involving the sort of the process of looking at evidence. It's also not a national sort of this is a specialty group who does that. So the methods that Eli referred to earlier, they can be applied for any guideline program. It could be done by, for example, one specialty developing or adapting their own guideline for their own areas of interest. What I'm talking now about is actually when we talk about bring that as part of a national guideline program. So again, so that enhances ownership of different stakeholders. Obviously, then if the guideline itself is of good quality and making the right recommendations, so enhancing quality of care and public health decisions, promotion of, as I mentioned, health well-being. But then in the end, it's a major tool to achieve universal health coverage, as we all expect. So in terms of what should be done and what we are doing, so just a recap of some of the key issues. In the region, so evidence-informed policy making program has several elements. I'm not referring to all aspects of it, only referring to what's happening in terms of the support for countries' guideline programs. So within our web pages under the title of Evidence and Data to Policy. So if you search WHO EMRO Evidence and Data to Policy, you actually get to the landing page of the program. Within the landing page, there is one tab which is on training capacities, and it has a list of many web-based, free of charge, good quality, capacity building resources for different aspects of evidence-informed policymaking. Within those, there are 16 resources that are actually supportive of the technical efficiency related to guideline program, which is really good. We've developed a template for guideline presentation that is relevant to the context of the region. So that was developed in collaboration with colleagues in Egypt and in response to the country needs. But then this can be sort of used in other contexts, and we are releasing that as for a wider use. And we finalize a roadmap for country action at the national level. What are the key things that should be done, not just on the method, but on the establishment of the national program for the guidelines. And that I'm expecting that it will be released. I mean, it has been being finalized and will be released within the next 2-3 months. Then obviously, I mean, some good support that countries support for sort of specific things that they are also adding to their experience, apart from the program that you're probably aware of. I mean, supporting, for example, Qatar on some topic-specific guidelines. I'm really glad to see Dr. Al-Ansari with us on the call, and she was sort of she led the technical team that provided that support. We're working very closely with the Ministry of Health of Egypt. I mean, it's a wide-ranging program. So for the established national program for Egypt, I mean, it's progressing extremely well. It brings all different partners together. I mean, this will be a model to look at. And then in previous years, we also conducted a review of the national program in Iran that has been established a few years ago, but then sort of providing some feedback to the country to enhance that further. So what does it mean when we talk of a national guideline program? What are the key elements we talk about? So I mean, a new terminology in the context of evidence informed policymaking has become very common in recent years, especially since the COVID pandemic. We call it the ecosystem in which the processes happen. So, I mean, a guideline program, national guideline program, works only if in the context that there are laws and national regulations and commitments that allows the existence of such a program and also make it useful. So let's say, I mean, you cannot have a national guideline program if there is no legislative or sort of legal power for making such recommendations. So countries, they should have had stated here or there, that depending on the structure of the country, to allow that power to the Ministry of Health to, I mean, give advice to the professional groups to how to enhance their performance. It's also about national technical capacity. So there should be people who can do different steps. I mean, some of these technical programs we are doing is in line to enhance that capacity. Should be sort of adequate money to conduct those programs. We are not talking about big money, but it should be enough finance. And then obviously, I mean, sort of these technical capabilities should be also available. So I mean, it's one thing to say, oh, I have the expertise in the country, in the Ministry of Health. It's the other thing to say that expertise is actually available for this program. So in a way that those should be there. And then the stakeholders. So I mean, the guideline program, national guideline program only work if all the key stakeholders are committed to it. And in a way, being committed to it is not that, I mean, everybody comes and saying that, oh, please, let's do that. Sometimes some stakeholders might have hesitation, but regardless of the hesitation, when you plan the program, you should ensure those stakeholders are engaged. And sometimes it's needed that they are also, I mean, brought into through the processes based on the legal requirements or administrative demands. Then obviously the National Guideline Program is responsible for development of guidelines or adaptation of guidelines. So, but then again, when we talk of the program, there should be a national steering committee, whatever we call it. So it's not one sort, for example, director and his or her teams in the Ministry of Health. It actually should be the steering committee that involves the Ministry of Health, but also representative from the key stakeholders. So that's those who are methodologists, those who know the context really well, those who are, I mean, all of them should not be biased. Conflict of interest being well managed, but then also making sure, I mean, so they oversee the process, and that's the element that will add to the credibility of the agenda. Robust methods, use of method and quality assurance processes, that's the must for any such program. And then sort of having a national roadmap for action to making sure that these program work in practice really well. And then lastly, guideline without being implemented is a piece of paper. I mean, could be the best piece of paper, or I mean, nowadays there could be the best digital app or documents or sort of set of recommendations. It's only effective when it's followed. So again, so then within the development and within the adaptation program, there should be enough attention to the element of impact. So what would be the next step? So what is the dissemination plan? How we support implementation? How we monitor progress? What happens if people do not follow the guideline recommendations? What should be done and how it can be enhanced one way or the other? So based on the experience that countries have had in our region and beyond, I mean, there are some key things that are really needed for a good, successful national guideline program. The high-level policymaker commitment is needed. So the national guideline program is not something that a minister of health, she or he will be involved on a day-to-day basis. Definitely not. So it would have a structure, a steering committee, etc. But they should be committed to it and making sure it's happening. This commitment either comes when they are developing the agenda, or it comes because this becomes part of the legality of the process, so that the ministry is committed. But that commitment, especially at the start, that attention is really important, because such programs, by nature of them, limit some of the freedom of decision making that different groups have. And in that sense, it's really important while we make sure the best recommendations are being made, but at the same time, the program is supported so that the program is well established, showing its effect, and then obviously everyone will come on board. Bringing all the stakeholders on the table together. So I mean, I've referred to this already a few times now. The issue is that it's absolutely important to make sure this is happening. And then obviously it can be done only properly if the national capacity has expanded for the need. I mean, whether it's adaptation or development, and then also the process, the follow-up process to make sure the guideline is best used in practice. So, I mean, in terms of responsibility and the nature of the work, I understand that, I mean, Eli has already talked about, I mean, sort of the adoption, adaptation, and development of the guideline, and sort of what it meant, what this terminology. But when we talk of a national guideline program, there are three scenarios, basically. And this is important to identify, because sometimes we sort of, let's say there is a good guideline, and everybody says a good guideline, it's a good guideline, it's suitable. Then we say, okay, but it doesn't need to be part of the national guideline program. That's not the case, basically. It should be. By that, I mean, so a guideline might actually come from one source or the other. It could be coming from another country. The country might have a very good guideline they've developed for one reason or the other. My country thinks that is suitable to be used in my country. Or could be developed by a sort of a national society, a group of healthcare experts, one in one location or the other, and they recommend that to become a national guideline for action. This is quite common by professional societies, and sometimes, of course, professional societies, they recommend the guideline developed by an international society. To accept those recommendations, a guideline as a whole, or accepting the recommendation within the guideline, the national guideline program has a responsibility for them. First of all, I mean, a guideline should become a national guideline if it addresses the needs. So there should be a process to identify what are the key things that we need recommendation on. What are the questions you are asking? I mean, the sort of the PICO question, the key questions that, I mean, we are not sure that the best answer are given in practice to them when the care is being provided or when the decisions are being made. So making sure the guideline is a good guideline on diabetes, but does it answer the questions that we have about diabetes care in the country? So it has the focus, but then also develop using valid approaches methodologies. So applying appraisal tools for assessment of the guideline, and sort of noting that whether those processes are followed when then potential recommendations are being made. So if it meets all the criteria, I mean, sort of, it means addressing the needs and it's develop based on good methodologies. And then it also doesn't need to change any of the recommendations, so the recommendations can be used as is in the country. Then the committee decides to adopt it. And so that's a decision. Adoption doesn't come passively. That's a decision that this recommendation is good for my country. I adopt it for my country, and I ask release it for action as such. So in a way, it's a decision-making process, but then the decision-making process that involves accepting other people former recommendations for action in the country. Then obviously the most common scenario, or not the most common, so the common scenario is also development. So development happens when there is no notable existing guideline to respond to the needs. I mean, you start from scratch and follow the process of developing your recommendations. And or when there are existing guidelines, but when they are assessed, you realize, oh, this might be a good guideline, but it's not responding to our questions. It doesn't address the needs that we have. Or when you assess them, you see they are trying to answer the questions that you have for your country, but then the quality is not good. If the quality is not good, then you put it aside. So then the guideline, you should start from scratch. So that's the de novo development happened. And lastly, the focus of today's discussion is the adaptation, which is the major needs. Why do we need to adapt guidelines? And why shouldn't we go for sort of guideline development from the start? Well, first of all, I mean, the context affects the applicability and the use of a guideline recommendation. So the healthcare setting affects what recommendation is best for the setting. The disease profile in a country may affect the effectiveness or cost effectiveness of one recommendation against the other. And obviously also sometimes availability of resources. Let's say, I mean, if you're talking about in a context that is resource poor and not, for example, enough radiology capacities exist in the country, then obviously you need to think of the recommendation that make the best for the setting while those capacities are not being provided for the country. The other issue is that sort of, even, for example, let's say, I mean, you are not, so you're talking of a context that might not be that different, but then you prefer to adapt from the existing guidelines because adaptation takes less time. And also it's less costly. So then that's a clear advantage to the national program. But however, I mean, so, and this today, I mean, after listening to Ellie, I mean, we all agree adaptation is not, we sit together and we decide to change the recommendation. No, it has methodology. It needs to follow certain approaches, and those approaches are need to be followed to ensure that the guideline is valid and followed. So this is my last slide here, but in a way, I mean, in this slide, I will spend a few minutes because I'm talk of, so I didn't have enough time to make it well animated. So, but then in a way, I go to some minimum criteria. So when we talk of a guideline adaptation program, so regardless of what program or what methodology the country accepts or selects to follow for guideline adaptation, there are minimum things that should be followed. So there should be a criteria for priority setting. Which topic requires a guideline? I mean, talk to clinical teams. I mean, even if you go in a hospital, I mean, you talk to some senior clinicians. Well, sometimes some people might tell you, oh, we don't need a guideline. And that's another discussion to have. But then as soon as they accept the guideline is needed, suddenly you will end up with so many different guidelines. I mean, recently with Dr. Kharandish, we met or we engaged with a major professional society in one of the countries of the region, and they had drafted 90 guidelines for their society. I mean, in a way, so, but then do all of those require a national guideline? All those topics require spending as a national program? Not necessarily. So the priority setting is not something that would be a fancy knowledge, but it should be areas that are important for the country. The disease, for example, the burden from the disease or public health challenge, or it's very costly to manage. So, I mean, these two are the main criteria. But the second thing is that also it's not, well, disease is, for example, let's say there is a high burden of a disease in the country, and then that's on its own is not adequate to say that this topic or this disease is a key topic for a national guideline. there should be also concern, legitimate concern, that you are not exactly sure the best treatments or the best approaches are being used in the country. So when you have a problem, a challenge, and then also you are not sure that the challenge is being addressed across the country in the best way. When these two together, these are the main criteria for a guideline. There are other criteria, of course, but these are the minimum main criteria. But who decides that? The national committee, the team that's responsible for those national policies. We talk of, guideline development groups. So even when we talk of adaptation, the terminology is more or less the same. And I don't know. So, whether Ellie agrees with me or not. So even in the adaptation process, usually the terminology is kept. So guideline development group, because they will be defined as a recommendation. And then the technical team that supports. So these are needed. And the guideline development group is not a standing group. It would be differs from one guideline to the other. The same for the adaptation process. So even adaptation requires scoping. The scoping, why the scoping is needed? Because the scoping is about what are the questions I'm answering. What are the key questions that need to be answered? It's sort of the example I usually make is that, so you want to go for shopping. If you know which need you are going to answer, so when you go for shopping, you are very specific to what to look for, what criteria should be there. But sometimes you may go for shopping saying that, oh, I'm going for shopping, I'm going around. So then you may see something that you may end up even buying without needing that. So the scope is that guideline. So I want a guideline that addresses these questions related to this disease, giving these criteria or these, for example, target groups. So the PICO questions that are very specific. And again, for every PICO question, you need to think of, is that a big problem? Is that an issue that requires a recommendation in my country? If they get, if that's yes, though, that becomes your key process. Then obviously this sort of selection of existing guidelines for adaptation, so updating evidence, adopting the recommendation, etc. And I'm sure all those steps, Ellie has given ample details about how those processes should be done. Well, not sort of, we listened to Ellie's presentation, and I'm talking about the minimum criteria right now. So we see that adaptation is not that easy. So, it takes time, but still it would be much easier and also less time consuming and less financial intensive for the country. So it's still, adaptation would be a good program. But when we talk of a national guideline program, then it's not just having the steps here, because the steps are about methodology, what to do first and then second. How, if you, let's say, a group of us on this call, we want to develop a guideline, we need to follow these steps, okay? When we talk about national guideline program, it becomes whose role is for priority setting, who makes decision about the membership of the guideline development group, what are the minimum criteria on who should be on the guideline development group, the technical support team, how you select them, how you train them, how you keep them engaged, what's their role, how do you manage the conflict of interest for those processes, who finalizes the scope and agrees for the scope of the guideline, who reviews the process, updates the process, how the guideline development group meetings are being managed, how all those decisions are being documented, how the final decisions are being made. So all of those become part of a national program, and that's what we call the roadmap for national program. And as I said, we hope that the draft the draft is final as a report will be published by the end of the year. And these together, with those role and responsibilities and sort of different stakeholders in the country, different roles, and sort of the finalization of the process being that, so how it's going to be released, what would be the format of presentation of a guideline so that it's user-friendly, and also in a way, it provides sort of a, a coherent package, so that, it would be easier for clinicians. If they use one guideline, they go to the second guideline. With that experience, the second guideline is also easy to follow or easy to find the information you need into it. So that's all together. When you talk of the methods and then you think of who is responsible for the method at the national level, what does it mean? And how do you make sure that the resources are available and the institutions follow those, then that becomes a national guideline program. So then going back to all those discussions we talked about sort of at the start from the it's not just a method, it's about the ecosystem and environment, and also linking that with action in the end. So many thanks, and I stop here. Thank you.
Thank you, Dr. Rashidian, for the great presentation. I mean, you talked about the national program and also the regional roadmap for establishment of this program in the region at national level. But you also pointed out a very important topic and subject that, I mean, as we discussed, I mean, in this session, that how much is important to have is robust methodology and approach for conducting this adaptation, but at the same time, how much is important to in the country that to make clear what is the role and what is the responsibility there, and the structure is very important. As we see sometimes some very minor things, for example, having the guideline review committee at guideline development group as a kind of multidisciplinary group, sometimes it's becoming a big challenge in the countries, that who needs to be included in the guideline development group. Sometimes having different groups, such as having physicians, nurses, and who is going to implement the guideline, who is the stakeholder of that guideline as a part of guideline development group. This can be a kind of sometimes challenge the country to having this national program. So as you mentioned, having the methodology in place, having the technical capacity, and also having the structures, I mean, making clear that who is responsible for what during this whole process is very, very important in the country to have this program, I mean, to be implemented efficiently and effectively. Thank you so much, Dr. Rashidian. I think that now we have, I see that you also shared your presentation. Am I right? Oh, thank you so much. I wanted to ask you for this. So we have now time, 5 minutes for any question, comments to share with us, your comments. You can just, colleagues, you can just unmute yourself and share with us your thoughts. Dr. Lubna, please.
Thank you very much, Dr. Rashidian, and I would like to just to say that what you are doing in the region under your leadership and with the fantastic efforts of Dr. Mernaz is really great. And this series of webinars is in itself a fantastic thing, but also the other aspects of tools and resources that you have produced over the past 1 or 2 years. I think that was fantastic. And we just, I just echo what was said, that I mentioned it as a comment to the earlier presentation, but we need to, the region has capacity and is willing to make the change. And I'm sure that every country is really, or all the audience, I wouldn't say countries, but those people who are here are willing to make the change. And they just need the efforts to organize these wonderful technical capacities within this audience in order to produce the best for our region. So I'm optimistic that things will be better, but we need to work together. I think that's something that we have learned with the experience with working with Qatar and their guideline, and we've learned a lot, and I think it was something reciprocal. And also, I think the national, the leaders and the countries, the policy makers need to have this kind of orientation or appreciating I'm sure many of them they do, but when they are busy, they forget about it. So we probably need to have some innovative methods by which they really think that this should be the priority, even if they cannot pay for anything else. Paying for evidence and translating it into policy should be priority number one for any policymaker. Thank you.
Many thanks. Manuel, is that okay if I just respond
Yes, please,
in reflection of what Lubna mentioned?
Yes, please, Dr. Arash.
Yeah. So, no, I mean, first of all, I fully agree. And the technical capacity and then the political demand, I mean, the demand side of it, and also then the support for it, they go together. I mean, the country might, I mean, countries sometimes ask for guideline program, but the national capacity is not strong to make it really a good program that adds value. I mean, in different areas of requirement, I mean, not, for example, WHO has a lot of useful guidelines, but not all the needs of the countries are responded by WHO guidelines. And so the countries' needs are bigger and the contexts are also different. A guideline that is applicable at the global level, I mean, depending on the topic, it may require adjustment, adaptations in certain recommendations for the context. So all those elements are there, and the policymakers, I mean, role is really important. I would say also is part of the job, I mean, within the country as well. So I mean, in a way, so the within ministries office, those program managers are the key who actually they make the agenda for the ministers. So I mean, it's also important that that capacity, that linkage within is increased and the demand is generated inside. What I want to say as the good news is that obviously, I mean, in 2019, as I mentioned, that was the statement of the decision the ministers made. So within that, the sort of resolution for evidence-informed policymaking, so a specific reference to the guideline. Naturally, it became part of the WHO Regional Action Plan for the program. But then in the sort of just a month ago, over a month ago, in October, in the meeting of the ministers for the, what we call the regional committee, the annual meeting of the ministers when they decide about the program, there was a specific session on guidelines. So then, so we highlighted the need for national guideline program. We referred to the experience of countries of the region. And I mean, the reaction was positive. So we are hoping that, I mean, while we are expanding the areas of work in the sort of region in terms of technical capacity, we should actually also respond better and have more demand from countries coming forward. So the other good thing that I would say is also, I mean, sort of we have Eli with us, and I'm really grateful for him and his team support for the program. So one of the best groups globally in terms of guideline methodology. So based in our region, based in Lebanon, in American University of Beirut. Your team, Lubna, in King Saud University, a strong team. So I mean, I think that Sameh was also on the call. I guess I think I saw him in the call when I looked at. So that technical capacity that you have, your team have, I mean, is absolutely important. In Iran, there are certain things that are really strong methodology of guideline experience. And then new teams, I mean, the two out, I mean, Mehnaz, I mean, please sort of, you may wish to add more details, but while we work with Egypt, right now, I mean, I would say there are individuals in the country that they, I mean, in a year, they can actually lead and support other countries very strongly for such programs. So in a way, there is growing capacity inside the country, in the region. And these capacities, some of them are well recognized at global level, and some of them will be recognized better in their own country and also globally through this program. So we sort of, we are really keen to, and as you said, optimistic that this program will continue to go forward. And in a way, is the main purpose in the end is that to make better decisions for patients, for public health. And that's the aim all of us had. I mean, for WHO, we should not be investing on it if it was only for developing documents, but actually making sure these are responding to the needs of the countries.
Yeah, thank you, Dr. Professor Arash. If I may add here, yeah, here in Qatar also we have our established the program where we have the full component, and we have the regulation and the ministerial decree for the committee that oversee the program. We have our experience with the stakeholder. engagement, and we have our process in a place for development, updating. We have approved frameworks to develop and update guideline, where we are happy and willing to support the initiative in Egypt, and we can contribute, and of course we will learn through this. So we can add our resources and ourselves at the disposal of this initiative, so we can support the program.
I'm really grateful. First of all, I'm very happy to hear, I mean, about the progress, the capacity going forward, etc. But also I'm grateful for the readiness to support other countries. Definitely, I have not referred to all the capacities existing in the countries, and I'm sure there is many more as well. What I really like to see also more is that sort of departments and academic institutions seeing this as an area of, I mean, one area that Doctor, I mean, we find a problem there is that, so for example, you talk to academic institutions, medical schools or schools of public health, they have a strong program. So on public health, on the sort of social medicine, on epidemiology, on clinical aspects, but then the technical capacities needed for the guideline program are not part of that. So there are really important that within academic institutions, there are also people who take this as their academic job, academic focus, so that they become the resource for everyone in all these.
We do have the academic institution and board. They're playing a major role in our. We do have.
No, I wasn't talking about Qatar. No, I was actually adding to your point.
Yeah,
I was expanding it. I was saying that. So I mean, this is within ministries, and the capacity within ministry is essential. But academic also, the points as Dr. Rasmi you mentioned, I mean, is also important. And many thanks for highlighting it. That's valuable.
Thank you.
Thank you so much, Dr. Rashidian, for your keynotes. And also, if Ellie, do you have any final word, please? 1 minute. Thank you.
No, just again to thank everyone. I agree with what has been said, the importance of learning from counter experiences, to think about our common goals, resources that we could share, and the importance of, institutionalizing these efforts, as Dr. Rashidian has said, the importance of collaborating, as Dr. Lubna has been saying. I think we have the potential, just getting things done. And to be honest, I think, in a long time, I feel this is happening now in the region. So thank you for supporting that, and we're looking forward to be part of this.
Thank you. Thank you so much. Thank you, Eli. Thank you, Lubna. Thank you, colleagues. So, Dr. Arash, just for closing remarks, and then, we want to have a group photo. So please, and we have just 2 minutes.
No, I don't have any closing remarks, so you are in charge. So if you want to say, if I say anything, I would say thank you, Mehnaz, and thank you to your team, to Malika, and colleagues who are behind this, and obviously the IT team in WHO. So I'm very grateful for this. I mean, that's much appreciated.
Thank you so much. So I also want to know, on behalf of our team and also myself, to thank you, our presenters today, for the great sessions, for the great interactive sessions. And also I would like to thank everyone, all participants, just for bearing with us for these 3 hours. And I'm so happy to see you, that many of you were with us. I mean, just in our previous session, and you attended this workshop as well. And I hope that you find this session helpful to what you wanted and you needed. So we will have our next session on Great Circle Approach on 11th of December. And you can find the Zoom link and everything on the poster, which is also uploaded just a few minutes ago on the chat box. And that would be, again, the 3 hours session from 12 to 3 Cairo time. So now I just want to ask you, please, if you turn on your cameras. So in that case, Malika, my colleague, will just take a photo, a kind of group photo just as memory. And then you can find all these presentations, recordings, and photo later on EDP webpage. Malika, just let us know when you just finish your taking
I have
photo.
photos, but I think not all colleagues have turned on their video. So shall we wait?
This is fine. I think some colleagues might.
Okay.
Okay, again, thank you so much. Thank you. See you again on 11th of December. Thank you. Bye-bye.
Bye-bye.